Just a minute. Okay. Yeah, Edmond. So Edmond, I tried to research a bit on your question as well, because I've never really thought about it in that sense. So yeah, but when I check, just like what I said, you usually don't have that kind of classification, okay? Because cases that will cause an acute obstruction of your airway, I mean, I'm sure you've got diverse cases that will end up causing acute obstruction of your airway. So if you're supposed to list them, you'd have so many. I mean, even sometimes when you have a very, very bad pneumonia, you could have a distraction of the airway as well. And then, I mean, that will be an obstruction to airflow. So just as I said, there's no categorization as such for acute obstructive pulmonary disease. However, just as I said, that when you have a chronic condition, you could have an acute exacerbation of that. Like what I use the asthma for an example. You have a patient who's asthmatic. Patient can develop an acute exacerbation of the asthma, and in that way you can say an acute obstruction to the pulmonary airway, but there's no classic medical term for that. Okay. All right, you're welcome. So do we all get why you would have the hyperresonance and then the loss of cardiac downness, or you want me to go over?
Yes.
So please go over.
Can you go over, sir?
All right, okay. So what's happening is that the airway has become obstructed. Ideally, you expect that even though you expect to have air in the airway, in your case of an obstruction, it's like the air, which is supposed to move through the airway to get to the alveoli where you have that gaseous exchange with oxygen going in and carbon dioxide coming out. That air is trapped in the airway, basically let me use the word circulation in quotes, or it's trapped in your airway. Okay, so it's trapped in the tubes. Okay, so the air gets trapped at the distal aspect of your obstruction. I mean, the air gets trapped at the proximal aspect of your obstruction. So you have maybe the airway, and then maybe there's an obstruction there. Okay, and the obstruction in this case is an inflammation. You remember we said when you have an inflammation, you eventually you can have secretions and things being formed, okay, as part of your inflammation. And this chronic inflammation would sometimes lead to fibrosis, which will close the airway. That's one. Or it will lead to secretion production, excess secretion production over there. And that's why the cough that comes out is wet. Okay. Once you have secretions, excess secretions, or you have any form of fibrosis, it blocks your airway. So when air enters, the air is not able to travel the usual path and finally get to your alveoli for gaseous exchange. So you have a lot of air which becomes stagnant in the airway. You understand? So there's stagnation of air in the airway. And once this happens, when we hit your chest, it's going to, instead of we hearing the usual resonance, when there's just normal amount of air, because you have excess air being stagnant in your airway, when we hit your chest or percuss your chest, it's going to sound hyper resonant. And the reason here for the hyper resonance is because you got excess air trapped in your airway. Are we okay with that part?
Yes, sir.
And ideally, when you hit over the surface of the heart in the middle of the chest, okay, see where the heart sits going to the left side. When you hit that side, we expect it to be what? Down. That area is called the mediastinum. The area between the two lungs is called the mediastinum. There's no lung tissue in the mediastinum. So when you percuss the mediastinum normally, it's supposed to sound down. If there was a lung tissue there and you percuss, then we'll say that part is also supposed to sound resonant, because lung means air. But when you percuss the mediastinum, ideally it's supposed to sound what's down. But when the patient develops excess air or excess air being trapped in the airway, it gets so much that it obscures that dull sound you are supposed to hear when you percuss over the heart. Okay, so now when you percuss, because you are not even percussing over the lung and you are percussing over the heart and you expect it to be dull, that dull sound has been obscured by the obstruction in the lung. So the whole area is like full of air. So it sounds what? Hyper resonant. Okay, so when you hit that area, we'll say that there's a loss of cardiac dullness. Ideally, when you percuss over the liver or the heart, it's supposed to be dull. When you percuss and you don't hear a dull sound, then it means there's some sort of issue over there. There's some sort of air extension over that area. Okay, and that gives you a clue that go to your lungs. You might have a problem. Either the lung is burst and it's leaking air into the mediastinum or over the surface of the liver, or the lung has become too distended with air that is obscuring the normal dull sound you are supposed to hear when you hit over the heart or the liver. Okay. So the management usually looks like asthma, because you know asthma, you'd have chronic and then maybe there's an acute exacerbation. So chronic bronchitis is close to that. So what you have is you are going to manage like the way we manage asthma. So you have a patient who is stable, who hasn't decompensated. So the body, as I said, tries to keep a homeostatic, a sort of balance. So a usual chronic bronchitis, your patient will be stable. Okay, so once the patient is stable, you are managing it like the way you're managing asthma. You give your patient 2 inhalers. We talked about asthma. We said we have the reliever and you have the preventer. The reliever is what you are going to pump in when you have an attack. So if all of a sudden your airway starts to close or the obstruction becomes severe, then you need a reliever. The reliever, an example is Ventolin or salbutamol. Okay, so usually we give them relievers. And then we have the preventers, which even without an attack, they can just inhale morning and evening just to open the airways. And the preventer here is we have Symbicort, which is a combination of budesonide and formoterol. Okay, and then we have Seretide, which is a combination of fluticasone and salmeterol. So when you look at it, you can see it's a combination of a steroid. So in the case of Symbicort, the steroid is budesonide. In the case of Seretide, 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 the steroid here is fluticasone. So it's a combination of a steroid, and we know steroids are what? Anti-inflammatory. Okay, so they combine steroid and then something that will open your airway, a beta-2 agonist, like the way salbutamol is a beta-2 agonist. So we'll combine the steroid with something like salmeterol or formoterol. So whilst you are preventing inflammation, we are also what's opening your airway. These are what preventers. It will prevent you from having an attack. But once the attack comes, we'll put you on quickly on the salbutamol. The reason why the salbutamol is a good reliever, some man might ask that, okay, budesonide also contains formoterol, which is a beta-2 agonist, which opens the airway or a bronchodilator. Fluticasone has salmeterol. So why can't we use those ones too as relievers? Okay, we are looking at the onset of action. When you take medication and you know there's an onset of action for every medication, salbutamol works faster. So we don't need you to pump salbutamol and then you are waiting for 1 hour before it would cause bronchodilation, you see. But then the preventers, it takes a while before they cause bronchodilation. But salbutamol, as soon as you pump it in, instant, the airway starts opening. And that's why it's a good reliever. Okay. But once your patient is not stable, and what will usually tip them off is when they have an infection. So this patient has chronic bronchitis already, the airway has become inflamed. And on top of that, they develop some infection, upper airway infection, spreads down there and starts making things worse. Then they will go into a decompensated phase. Okay, once they go into a decompensated phase, you have to step in. In the decompensated phase, it means that oxygen levels will be dropping, they will feel sick basically. So you come in and then you start them on oxygen. Then you try and manage them like the way we managed our asthma. We said you give salbutamol. If salbutamol doesn't work, you give ipratropium, okay? And then you give hydrocort, then you give prednisolone. Remember the stages in asthma. So once a patient has chronic bronchitis and presents to you with an acute exacerbation, it's going to feel like asthma. So you will manage it as such, okay? You manage it as such. The only thing that will tell you that, oh, this is a chronic bronchitis, this is not asthma, it's your history, because your patient will tell you, I'm not asthmatic, I don't have a family history of asthma, but then I smoke a lot. Or in the past 20 years, I've been working in the mining field or with lots of sand and dust. Then that would tell you, oh, this is a chronic bronchitis, but not what, an asthma, even though the presentations would look alike and the management would what, look alike. Okay, so that's it for chronic bronchitis. So you manage it like the way you're managing asthma. Your beta-2 agonist, so your bronchodilator, salbutamol. If it doesn't work, ipratropium. At the same time, when they come and you are trying to mix that, they are giving you oxygen. Your focus is on preventing inflammation. So you are pumping in your steroids as well. And when they are going home, you are discharging them on oral antibiotics and your prednisolone. Don't forget to do your investigations. And it's similar to what we talked about in acute bronchitis: full blood count, sputum for microscopy and culture, possibly GeneSpect, sputum for acid-fast bacilli, a chest x-ray. You need to do all that, okay? And what you see is that because there's a lot of air trapped in there for COPD patients, most of the time, their x-ray, you realize the chest looks a little bit barrel, like a barrel shape. And we are talking about those barrels we tend to see in cartoons when they put wine in some barrel and the top looks a little bit narrow, then the middle is wide, and then the down is narrow, those barrels. So the chest will actually look like a barrel shape on an x-ray because of the excess accumulation of air in the airway. Okay, it pushes the chest out. So you see what we call a hyperinflation of the lungs, okay, on your x-ray. It will show you that. The next one we are going to talk about is emphysema. Okay, so as I said, the major thing is chronic obstructive pulmonary disease. So whatever we are looking at is causing some sort of obstruction towards airflow. Okay, the bronchitis we talked about, our focus was on the bronchus. In this case, our focus goes beyond the bronchus. So with emphysema, you are talking about the alveoli and then the very, very small branches of the bronchioles or the terminal bronchioles, the last part of the bronchioles. You know, the lung, you go from trachea to bronchus to bronchioles, then alveoli. So the distal part of your bronchioles, okay, the part that is close to the alveoli, and the alveolar wall itself is what would be involved in emphysema. Okay, so emphysema, you go beyond the bronchus. In emphysema, the bronchus is actually fine, but then you go down and then you realize that no, there's still airflow limitation. Oxygen is not getting into the blood, and carbon dioxide is not really coming out because the portion of the lung which is supposed to be involved in that gaseous exchange has become destroyed. Okay, so in emphysema, there's a destruction of the alveolar wall and the wall of the terminal bronchus. And once it becomes destroyed, it would heal with fibrosis. Okay, so that's what is going to happen in emphysema. Commonest causes is similar to the chronic bronchitis. So smoking, most of the patients who smoke generally, and that's why the general term of COPD comes in. We'll say COPD and smoking. Most of the patients I've seen who have COPD smoke. And even when they develop the COPD, they are unable to stop smoking. They still keep smoking, and that's what kills them. Okay, so smoking, very, very important. Industrial fumes, very important. So your location, even you might be then not be working in this industries producing biomass and fumes and all that. But if your company is close to that part and you've worked in your company for 30 years and for 30 years constantly, you're always inhaling this, you can actually retire and then you have an emphysema. So we all have to be careful. One thing about the lung or the alveoli is that there is a certain enzyme, okay, which well, what's this enzyme is that it does is that it tends to prevent breakdown of proteinaceous substance like collagen and all those things that form organs, okay? It tends to prevent the breakdown of such things. And an example is what we call alpha-1 antitrypsin. If you remember our physiology and digestion, we said trypsin is involved in breaking down of proteins, right? So antitrypsin prevents the breakdown of protein, okay? So when you have good amounts of antitrypsin, your proteins don't break down easily. When your antitrypsin level falls, then all those enzymes which are involved in breaking proteins in the places where they're not supposed to break down proteins will have a field day and they'll break down the proteins and you're going to lose the proteins. When you look at your alveoli, okay, the structure is made up of proteinaceous substance. We don't expect that your alveoli will break down. And alpha-1 antitrypsin activity is very, very key to keep your alveoli wall intact. But when you develop a deficiency in alpha-1 antitrypsin, then it means the trypsin, all those things that break down protein would have a field day and they will destroy walls of organs, okay? So once you have a deficiency of alpha-1 antitrypsin, neutrophil elastase, as the name suggests, elastase means it's going to break down elastin. The lung is made up of elastic tissues so that it can be able to expand and relax. So once you lack alpha-1 antitrypsin, neutrophil elastase will have a field day and it will lead to destruction of your lung tissues. Okay, so most people who have emphysema, we check and we realize that they have some sort of alpha-1 antitrypsin deficiency. Possibly this could be due to the smoke. You know, smoking does a lot of things. Smoking can inhibit function of a lot of structures. So you could have a problem there where you have a deficiency in your alpha-1 antitrypsin levels. And so the alveoli becomes destroyed. On top of that, the smoking will predispose you to infection because let's look at chronic bronchitis and emphysema. There's an obstruction to airflow, right? So you've got stagnation there. Air is not able to get in for diffusion purposes. So you've got the air trapped in there. On top of that, you are smoking, and the smoke is able to impair the action of the cilia. The mucosa of the lung is made up of something we call cilia, okay? C-I-L-I-A. And this cilia beats to propel bad substances up the lung and then you cough them out. The smoke can impair cilia function. And once smoke impairs cilia function, bad substances, microorganisms, and things that get in are unable to come out. So they will stay in there and they would induce an inflammation and they will tip you into a decompensated state. Okay, so if you have a patient who has COPD, we always tell them stop smoking because now the lung is basically destroyed. So you stop smoking. But when you keep smoking, then the smallest or the slightest cilia function left would also be what's compromised. So bad substances go in, but your cilia is paralyzed. So it's unable to beat these substances up for you to expectorate. Then you'd have an issue. Okay. So there are mainly 3 types of emphysema. It shouldn't be difficult. It's basically is based on the classification is based on the part of the alveoli that is destroyed. Okay, so if you have an emphysema where the whole alveoli, which is involving all the alveoli, every part of the alveoli, then we say PAN. Once we say PAN in medical terms, we want to say everywhere. When we say panlobar, remember when we're talking about pneumonia, I said panlobar pneumonia means all the lobes are involved. Once we say pan-asignar, it means every part of the alveoli is involved and is destroyed. Okay. Then you have paraseptal, and paraseptal is the part of the alveoli which is distal to the lung. So this part of the alveoli is basically getting close to the pleural aspect of the lung. Okay, so you see where the lung is, you have the pleural aspect of the lung, and then you have the medial aspect, which is close to the heart. So if the alveoli close to the distal aspect, which is close to the pleural aspect, okay, that's the only part that is involved, then you say, oh, you have a paraseptal emphysema. But if the alveoli, okay, or a little bit more closer to the medial aspect of the heart, then we say you have what? A centri-asignar. Okay, so centri-asignar emphysema is localized or located proximal to the what? Bronchioles. Okay, and then the paraseptal is distal, away, close to the pleural, and pan means every aspect of your alveoli is involved. Okay. Clinical presentation is similar to chronic bronchitis. So there's coughing, there's difficulty in breathing, because as I said, it both falls under the main heading COPD. So the symptoms will be the same. Okay. In all this case, there's lack of oxygen going in there, and then lack of carbon dioxide coming out of the body. So the symptoms will basically be the same: difficulty in breathing, you breathe fast, and all that. And as I said, because they are having that issue of breathing, they try to force the carbon dioxide out. So when they breathe out, they try to push. So there's a prolonged expiration. And the main reason for this prolonged expiration is to what? Push carbon dioxide out. Okay. Because they have a respiratory distress, they will use accessory muscles to breathe, just like what we've been talking about all this while. And the lungs basically are hyperinflated because the lung just keep filling with air, but then the air is unable to diffuse through the alveoli and get into the blood, and carbon dioxide is unable to come out. So it's just like you are filling a balloon with air, and there's no diffusion. So the balloon keeps getting bigger. So the lung keeps becoming hyperinflated because it keeps filling with air. However, there's no diffusion, okay, or there's very, very small diffusion. So once the lung is hyperinflated, when you percuss over it, it's going to be what? Hyperresonance, because there's more air in there than normal. And there will be loss of liver downers, just like the other one we talked about, loss of cardiac downers. In this case, there will be loss of liver downers. So, Kwasigan, let's take your question and then we'll go on to the next slide.
Okay, so I'm saying that before someone comes with the emphysema and you ask the person not to smoke, wouldn't the cilia be destroyed already?
All right, okay, so it's a good question. It's a good question. So yes, so you would have some of the cilia destroyed, but you see, when it comes to smoking, the patient is better off stopping at a point than you just giving up and say, okay, the cilia is all gone, so don't, keep smoking. What happens is, you see, our body is able to, just like the way we keep making cells, okay, if the patient comes to you and then most of the cilia is destroyed, constantly your body tries to fight infection. So it's like when you have a wound, even if your body is trying very hard to repair, eventually it repairs it. Maybe you have a scar over there. So eventually you would have the body trying to make some additional cilia, even though you have the cilia being destroyed, you have the body trying to make cilia, okay? Once you're alive, constantly your body is undergoing, your cells are undergoing mitosis and all that. So you have the body trying to make cilia still. And if you keep smoking, then it means you're going to impair the baby cilia that even your body is trying to make. So the patient stopping goes a long way to allow the lung to some time to be able to make some new cilia. Okay.
Okay. Then besides that, with the hyperinflation of the lungs, does it get to a point where it's the lungs burst or it loses its structure?
Okay, so
there's more filling of air.
Yeah, so that is the what you've hit the nail on the head, and that is what emphysema is. Okay, so when you look at the diagnosis of emphysema, we say you have a permanent enlargement of your terminal bronchioles. Okay, and then eventually it's going to lead to distraction. Good thing about the lung is that most of the time, once healing process comes in, it's not just like your skin, which you are going to have mainly fibrosis. The lung is able to pick up, and that's why it's even good to tell your patients to stop smoking. Okay, so once it gets hyperinflated, you know that the end game over there is what that is going to what burst. Okay, so that is what we mean by the permanent enlargement and eventually an alveolar wall destruction. Okay.
Okay, thank you.
You're welcome. So it ruptures.
All right.
Okay. So the complications, basically, of course, once you have that, you are going to develop respiratory failure. Okay. Because it gets to a point in time whereby oxygen is not going in at all, carbon dioxide is not coming out at all. So then we say, once we are looking at respiratory, you failed. Okay, so we tend to develop a respiratory failure over there. Then there's also cor pulmonale, and cor pulmonale basically means you have heart failure, and this heart failure is secondary to a lung condition. Okay, so if you have a heart failure, which is secondary to a lung condition, then we say that you have a cor pulmonale. So for example, you have a patient who has a pulmonary embolism, a PE sitting there, and because of that, it's increased the pressures in the vessels of the lung. Once you expect that the right side of the heart should be able to pump blood to the lung and get oxygen, so that comes the left side of the heart, right? But once you have anything in the lung which is affecting the right side of the heart to be able to push blood into the lung for oxygenation, with time, the right side of the lung will start losing its function. Okay, so the pressure in the lungs is so pulmonary artery keeps pushing. The right ventricles will keep getting bigger, and eventually, just like the way your left ventricles will keep getting bigger and hypertrophied when you have systemic hypertension. In this case, you have a pulmonary hypertension. So the right side of your heart will keep pushing, and then eventually it will get tired and that side of the heart will fail. So then we'll say you have a heart failure, but this heart failure was secondary to a lung condition that you have. Okay, so emphysema can actually cause you to develop a cor pulmonale. Your investigations, full blood count, you take blood sample and you want to check the level of carbon dioxide and then level of oxygen, and that's what we call arterial blood gas analysis. When you take and you have more carbon dioxide than oxygen, then it means your patient isn't doing well at all. Okay. Then there's a lung function test where we check the forced expiratory volume in 1 second and then a peak expiratory flow rate. And remember I said that because the air is trapped, basically when it comes to expiration, they have a difficulty. So they try very hard to blow. So sometimes you see patients with COPD and their lips look like a pears. We say they have pursed lips. So it's like they pouted their lip in a way just to try and get the excess carbon dioxide out. Okay. So ideally, when you do a lung function test and you check their FEV, which is forced expiratory volume in 1 second, you realize that it is reduced as compared to the normal person's forced expiratory volume in 1 second. Okay, so under normal circumstances, they are unable to bring out air. So they have trapping in there. Usually because oxygen levels would stay low in the blood, okay, because you have less amount of oxygen going in the blood and you have less carbon dioxide coming out of the blood. So you say the patient has what? Hypoxia or hypoxemia, okay? So less amounts of oxygen in the blood. Your body will compensate by making a lot of red blood cells, okay? Because red blood cells carry oxygen. So your body will think, oh, maybe I'm anemic. I don't have a lot of RBCs. Let me make a lot of RBCs so that I can be able to carry oxygen. And so you check their full blood count and you realize they have a lot of white blood cells. So we say they have what? Polycythemia. Okay, polycythemia. And what is going to happen is they are going to have excess carbon dioxide in their blood. And so once this happens, they are going to develop what we call what's carbonic acid in their blood. Okay, so we say that they will have a respiratory acidosis. Respiratory acidosis means that you are unable to breathe in enough oxygen. So as such, the carbon dioxide in your blood becomes excess. Once carbon dioxide becomes excess, it forms carbonic acid. So your blood becomes acidic in quotes. Okay. And remember, we said wherever there's less amount of oxygen going, you end up forming lactic acid and all that. In the same way, you are going to make less amount of you are going to have less amount of oxygen getting into your bloodstream. And once this happens, carbon dioxide will be more in the bloodstream. And if carbon dioxide levels keep going up, then you are going to develop acidosis. Okay. And your body reacts to this acidosis by acidosis or alkalosis. So the function of the body is such a way that it always buffers. If you have alkalosis, it would always buffer with hydrogen ions. Acidosis, it will buffer with bicarbonates so that it becomes what's neutralized. So in this case, you have an acidosis. So your body would undergo what? A buffering system to compensate. So in the end, you are going to have an alkalosis developing. Okay, this shouldn't be confusing. So there are 4 things: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Okay, these 4 things can happen to your system. The normal system, pH is supposed to be neutral, but the body can either undergo acidosis or alkalosis. Under acidosis, you can either have a respiratory acidosis or a metabolic acidosis. And under alkalosis, you can have a respiratory alkalosis or a metabolic alkalosis. Acidosis means you have a lot of H+ or hydrogen ions. Alkalosis means that you have a lot of bicarbonate or HCO3-. Okay, you remember our chemistry. So whenever your body has excess H+, then we say there's acidosis. Your body will compensate by making excess HCO3- or bicarbonate so that it will come and neutralize, form water, and then you have a neutral pH. You understand? Whenever you have excess bicarbonate, then your body would have to end up making more hydrogen ions, or your body will prevent you from excreting more hydrogen ions in your urine. So we keep the hydrogen in your blood, it won't come out of your urine. Then it merges with your bicarbonate and you have a neutral pH. That's the normal that is supposed to happen. But what happens is when you have acidosis, and this acidosis is due to respiration or inability for you to get oxygen into the blood, your body will compensate by alkalosis, but the alkalosis won't be respiratory alkalosis. The alkalosis will be metabolic alkalosis, okay? Whereas when you have metabolic acidosis, the compensation wouldn't be metabolic alkalosis, but what's respiratory alkalosis. So it's a balance. So the respiratory aspect is handled by the lungs, okay? And then the metabolic aspect is what the kidney does, basically. So the metabolic aspect is handled by the kidneys and all the other metabolic activities in your body. Okay. It shouldn't be difficult. I mean, if we're in class, I'm sure it would be a little bit more easier, but just know that ideally you expect there to be a balance. Okay, you don't expect to have acidosis, you don't expect to have alkalosis. A balance, ideally. Okay. Once the balance is gone, then you have a problem. You have to what? Compensate this balance. Okay. How do we compensate for this balance? If it's acidosis, then we want the body to make more bicarbonate to neutralize the acid. If it's alkalosis, then we want the body to make more H plus or hydrogen ions to neutralize the bicarbonate. Okay, how is this done? If the acidosis is coming from the lungs, the body is going to recruit action of the kidney or the metabolic action to come in. However, if the acidosis is arising from any other body, any other part of the body, apart from the lungs, which we call metabolic acidosis. An example is if you have a patient who has diabetes and develops a DKA, this is acidosis, but this is not respiratory acidosis. This is a metabolic acidosis because the patient has made a lot of ketone bodies. Okay, so how do we compensate for this? We have acidosis, so now the body has to undergo what? Alkalosis to be able to compensate. How will the body undergo that alkalosis? The alkalosis this time will be coming from the respiratory system. So when you have metabolic acidosis, the body will compensate by respiratory alkalosis. So it means you make more hydrogen bicarbonate, and the bicarbonates you are trying to make will be coming from respiratory alkalosis. So that's how the body balances your acid-base balance. Okay. It's a big topic, but I expect that physiology, they should take care of it. But basically that's it. And that's what is in the last bullet over there. You have a raised serum bicarbonate level because of metabolic alkalosis. Why? Because the body is undergoing respiratory acidosis because of lack of oxygen and increased carbon dioxide in the blood. So your body would have to compensate. And in compensating for respiratory acidosis, we'll call in the metabolic aspect of your body to come and make more hydrogen or HCO3 hydrocarbonates, okay, or bicarbonates. So we call them, and hence your serum bicarbonate level will go up. And we'll say, okay, now there's metabolic acidosis trying to compensate for the there's metabolic alkalosis, trying to compensate for the respiratory acidosis that has arisen